with technetium-99m, a tracer with ideal physical properties for scintillation camera imaging. This search met with initial success in 1982 when a group at the Peter Bent Brigham Hospital announced the development of technetium-99m isonitriles. Of the isonitrile compounds that were subsequently applied clinically, technetium-99m sestamib, cardiolite, has the most favorable biologic characteristics for myocardial perfusion imaging. Soon after the introduction of cardiolite, it became clear the new acquisition, processing, display, and quantitation protocols would have to be developed to exploit fully the distinct physical properties of this agent. Furthermore, new methods of myocardial imaging and new clinical settings in which they can be applied have been developed and evaluated. To explore the issues and opportunities posed by this new tracer, many researchers in myocardial imaging came together and presented their material. Some of these highlights will be presented to you on this tape. The information contained in this section will include an overview of cardiolite, mechanism of action, imaging protocols, and clinical applications. Clinical applications will include the discussion of coronary artery disease and myocardial infarction disease. The traditional agent for detecting coronary artery disease has been thallium-201. Today we have new technetium agents that give us a better imaging potential than previously possible with thallium. Our discussion in the next few minutes will explain these new agents, their advantages and disadvantages, and how they compare to thallium. Although thallium has been used extensively and successfully to date, the new technetium agents offer significant improvements. Better imaging energies allow us to dose more appropriately, providing information which is better as well as complementary. Cardiolite has been referred to by a number of terms over the course of its development and testing. These include technetium-99m isonitrile, MIBI, hexamib, RP30, RP30A, methoxyisobutyl isonitrile, and 2-methoxy-2-methylpropyl isonitrile. The generic name is technetium-99m sestamib, and the brand name is cardiolite. Throughout this tape, we will be using cardiolite. We will first discuss the differences between cardiolite and thallium as pertaining to their pharmacokinetic properties. Both cardiolite and thallium are distributed in the myocardium in proportion to blood flow. However, there are significant differences in their pharmacokinetic properties. Cardiolite clears more rapidly from the blood than thallium. Over 90% of the cardiolite activity is cleared in less than 5 minutes. It undergoes prompt hepatobiliary excretion. The half-time is approximately 30 minutes. Thus, there is little interference with hepatic uptake, with visualization with the inferior left ventricular wall. The 24-hour urinary excretion of cardiolite is 29.5% of the injected dose at rest and 24.1% after exercise. Cardiolite has very slow myocardial clearance. The half-time is approximately 5 hours, which allows for prolonged imaging time. Unlike thallium, cardiolite has no significant redistribution within the myocardium. The initial uptake pattern remains fixed over an extended period. This requires 2 injections to obtain rest and stress images. Rest and stress images may be obtained on separate days or on a single day. After the rest injection of cardiolite, the highest concentration of the tracer is in the gallbladder and liver, followed by the heart, spleen, and lungs. Note that within the first 30 to 60 seconds after injection, liver activity decreases with excretion into the biliary system. The blue time activity curve represents the gallbladder, and you will see that maximum accumulation occurs 60 minutes after injection. Since no significant redistribution of cardiolite occurs, a convenient and practical time for imaging is 1 hour after injection. The purple curve, which represents the heart, shows continuous visual improvement with time. From activity 1.5 hours after injection at rest, the count density in the heart is higher than in the immediate adjacent organs. Only the gallbladder has a higher count density. A recommended method of clearing the tracer from the gallbladder is to have the patient drink 8 ounces of whole milk 15 minutes after the injection is given. After exercise, the gallbladder retains the highest count density, with the heart retaining a higher count density than the immediate adjacent organs. Cardiolite offers a number of unique features over thallium as a myocardial perfusion imaging agent. Favorable patient dosimetry makes it feasible to administer a dose 10 times higher than that of thallium. This ensures higher quality cardiac images because of the higher count density and resolution. The prolonged myocardial state in count distribution and the higher count rate of cardiolite allow for the performance of gated myocardial imaging. This is not possible with thallium. The higher dose of radioactivity with cardiolite makes it feasible to perform first-pass exercise studies of ventricular function followed by myocardial perfusion imaging using a single tracer injection. This approach will be discussed in further detail later. Technetium has ideal physical characteristics for anger camera imaging. These ideal physical characteristics are a monoenergetic gamma of 140 keV and a 6-hour half-life. These characteristics lead to higher resolution and less attenuation and scatter than with thallium-201. Because no significant redistribution of cardiolite occurs, the timing of imaging after injection is not as critical as with thallium. This property provides considerable flexibility in scheduling. It allows for the uncoupling of the injection time from the time of image acquisition. This unique feature makes cardiolite particularly suited to imaging applications in acute ischemic syndromes, including assessing the effects of thrombolytic therapy and evaluating unstable angina. As an example, the tracer can be administered during an intervention, and imaging can be postponed to a later, more convenient time without loss of information. Finally, the technetium label is readily available in kit form, unlike thallium, which must be obtained from a cyclotron. A comparison of physical characteristics of cardiolite and thallium reveals important differences between these perfusion imaging agents. Both cardiolite and thallium are cationic. Myocardial resonance time is greater for cardiolite than for thallium. The implications of this concept will be shown on the following slide. The absence of redistribution is a major difference between thallium and cardiolite. This absence decreases the critical timing factor from injection to imaging that exists with thallium. The imaging properties of cardiolite and thallium also have important differences. Imaging with cardiolite can begin approximately 1 hour after injection. Because this tracer does not significantly redistribute, imaging can, if necessary, be delayed for several hours without loss of information. With thallium, imaging is generally begun approximately 5 minutes after injection. A complete rest-stress protocol can be completed with either product within 3 to 4 hours. Same-day rest-stress protocols for cardiolite are discussed later in this chapter. Total myocardial counts are much higher with cardiolite than with thallium. The combination of high myocardial counts and lengthy myocardial clearance time make cardiolite ideally suited for SPECT imaging. Thallium SPECT studies are limited by suboptimal physical properties of thallium, which result in a variable image quality. The minimal redistribution of cardiolite, combined with high count rates, makes gated SPECT imaging feasible with this agent. Unlike thallium, first-pass studies are also possible with cardiolite. Investigators have noted that although cardiolite is ideally suited for SPECT imaging, planar imaging is still commonly performed and may reflect greater experience and refinement of technique. Planar imaging is better suited for studies at bedside or in a critical care situation and requires a lower radionuclide dose and less strenuous patient positioning. The planar imaging recommendations are listed here. Multigated acquisition, or MUGA, is an option with cardiolite imaging. A standard 16-frame cycle MUGA is performed. Imaging time is 10 minutes per view. The patient is positioned supine and the left anterior oblique, or LAO view, which optimizes the separation of left and right ventricle, is obtained. Next, an anterior view, 45 degrees to the right of the LAO view, is obtained. Finally, a left lateral view is acquired with the patient in a 90-degree decubitus position. Alternatively, a 70-degree LAO view can be obtained with a patient in the supine position. The same positions, angles, and imaging times would be used for the rest and stress images. This slide shows planar images of a normal heart. A planar study was performed on a 35-year-old man with no history of coronary artery disease and normal exercise test results. A coronary angiography was not performed. 20 millicuries of cardiolite was injected at peak stress, and images were acquired 1 hour later. 24 hours later, a second 20 millicuries was injected. Images were acquired 70 minutes later. The right atrium, right ventricle, and atrial septum are seen. This rest study shows subdiaphragmatic activity, which is sometimes seen on images acquired more than 1 hour after injection. This slide shows planar images acquired in a 55-year-old man with hypertension and a previous inferior Q-wave myocardial infarction. The exercise test showed an ST segment depression consistent with ischemia. Coronary angiography disclosed total occlusion of the mid-right coronary artery and 70% occlusion of the left circumflex. Approximately 21 millicuries of cardiolite was injected at peak stress, and images were acquired 2 hours later. The REST study was done with a second 21 millicuries injection 24 hours later, with images performed 135 minutes after injection. The cardiolite study shows inferior and posterior lateral wall scars in both the stress and rest views, consistent with the previous myocardial infarction. In this case, a 58-year-old man with a history of diabetes and hypertension presented with unstable angina. A myocardial infarction was ruled out, and percutaneous transluminal coronary angioplasty, or PTCA, was performed on the left anterior descending coronary artery, or LAD. The exercise test showed an ST segment depression. Coronary angiography revealed 70% stenosis of the LAD post-PTCA and 75% stenosis of the distal left circumflex. Approximately 16 millicuries of cardiolite was injected at peak stress, and imaging was performed 105 minutes later. The REST study, performed 24 hours later, was obtained 70 minutes after a 16 millicuries dose was injected. The cardiolite study shows a partially corrected defect in the anterior and septal walls. Also note the papillary muscle is clearly seen. Most reports today using SPECT with cardiolite have employed acquisition parameters that were optimized for thallium. To fully utilize the superior imaging characteristics of cardiolite, the acquisition and reconstruction parameters of SPECT imaging must be optimized for this agent. A 64 by 64 matrix provided the most effective configuration and excellent image quality. The use of a high resolution collimator, particularly important because it provides a more constant resolution response with depth than with the all-purpose collimator. A 20% symmetric energy window on 140 keV, 180 degree rotation using 60 to 64 projections, and imaging times of 20 to 25 seconds per stop are optimal. For a same-day rest stress imaging protocol, acquisition parameters are as just discussed. The major difference between the rest and stress acquisition is the exercise acquisition is gated to the electrocardiogram. A gated tomographic perfusion study is acquired in much the same way as a static acquisition, except that the cardiac cycle is divided into 8 segments. Each of these segments is treated as one static acquisition. When the gated study is completed, there are 8 separate static studies corresponding to the 8 segments of the cardiac cycle. Displays created from the gated study are useful in identifying image artifacts and assessing wall motion. Shown here is an example of a normal cardiac SPECT study. The SPECT images were acquired in a 41-year-old man with no history of coronary artery disease. Results of an exercise test were normal. Coronary angiography was not done. The cardiolite study was performed using a same-day protocol. The subject was injected at rest with 7 millicuries of cardiolite, and imaging was done 60 minutes later. Immediately after completion of the rest study, the exercise study was performed. At peak stress, the subject was injected with 25 millicuries, and 60 minutes later, images were acquired. The patient was instructed to drink 1 to 2 glasses of milk approximately 30 minutes after each injection to promote clearance of the tracer from the gallbladder. Images were collected over a 180-degree arc from the 45-degree left posterior oblique to the 45-degree right oblique. 64 projections were acquired at both rest and stress. In this case, a 56-year-old man with a history of an inferior Q-wave MI had an ST segment depression on an exercise electrocardiogram. Coronary angiogram showed significant disease. The cardiolite study was performed using a same-day protocol as described above and was read as abnormal. The pre-PTCA study shows an inferior wall infarction and ischemia in the septal region. A post-PTCA cardiolite SPECT study in the same patient shows normal perfusion in the septal region and the persistent inferior wall defect consistent with the previous infarction. In numerous published studies, cardiolite has shown sensitivity and specificity comparable to or higher than those for thallium for the detection of coronary artery disease. Note these comparisons on the screen. SPECT sensitivity and specificity for thallium and cardiolite correlate well. A multi-center clinical trial in the United States and Canada revealed the following results. There was a 92% agreement between cardiolite and thallium in patients who underwent planar imaging for the detection of myocardial perfusion defects. SPECT imaging also demonstrated a high agreement between cardiolite and thallium. To assess the efficacy of cardiolite in the evaluation of myocardial viability, the patterns of stress defect reversibility from perfusion images of the tracers were compared. As we have discussed, the mechanism for stress defect reversibility of cardiolite is different from that of thallium. Because cardiolite does not have significant redistribution, two separate injections, one at peak exercise and the other at rest, are required for the assessment. While images acquired after the injection of cardiolite at peak stress demonstrate exercise-induced ischemia, images obtained after the rest injection show the pattern of myocardial perfusion. Improvement or normalization of an exercise defect on the resting image indicates defect reversibility and implies the presence of viable but hypoperfused myocardium. The exact agreement between cardiolite and thallium by planar imaging was 91%. By SPECT imaging, they were in exact agreement. Unlike thallium, cardiolite does not redistribute in the myocardium after injection. Thus, two separate injections, one at rest and the other at stress, are required to differentiate ischemia from scar. A 24-hour interval between the two injections is preferable for the detection of coronary artery disease. However, same-day studies are more convenient in clinical practice. To assess the accuracy of same-day imaging with cardiolite, investigators compared results of the same-day and separate-day cardiolite protocols with thallium studies and coronary angiography. Qualitative and quantitative comparisons between the same-day and separate-day studies were performed by 4 experienced observers. They found the same-day protocol with cardiolite gave results similar to those provided by separate-day protocol. The next step was to compare the rest-stress and the stress-rest injection sequences for same-day cardiolite studies. 18 patients with either an abnormal thallium scan or an abnormal coronary angiogram were prospectively studied with the 2 cardiolite injection protocols. A segmental comparison was interpreted blindly as normal ischemia or scar by 3 observers. There was an 87.3% agreement between the rest-stress and the stress-rest protocol. Investigators noted several advantages of a rest-stress injection sequence for the same-day cardiolite imaging. First, it provides better characterization of the perfusion defect. With the rest-stress sequence, the rest image obtained represents a true rest study, which is not necessarily the case with the stress-rest sequence. Since the rest study is performed first, there is no contamination from a previous cardiolite study. In a patient with ischemia but without infarction, the ischemic defect is seen on a relatively uniform myocardial background from cardiolite rest injections. In stress-rest protocol, myocardial background for the rest study is non-homogeneous. The Phase 1 study of cardiolite also showed that dosimetry is lower with a stress injection than with a rest injection. The same-day rest-stress protocol does have some limitations. Lesion contrast with the protocol may not be as good as when the stress image is obtained 24 hours after the rest image. The same-day rest-stress sequence requires a new scheduling routine that allows for exercise acquisition in the afternoon rather than in the morning. Finally, it could be demonstrated in clinical research protocols that if a stress study is clearly normal, a rest study is not needed. However, if a rest study is done first, both studies must be conducted. Investigators have optimized the doses of cardiolite to be used in a same-day protocol within the limits of a total dose on day 1 of 30 millicuries. For a 70-kilogram patient, they recommend standard doses of 8 millicuries of cardiolite for rest study and 22 millicuries for the stress study. Again, it is recommended that patients be given 8 ounces of whole milk 15 minutes after receiving the injected dose to clear the tracer elements in the gallbladder. In this protocol, imaging begins 1 hour after the injection for the resting study and 30 minutes after the injection for the stress study. The earlier post-stress imaging minimizes the effect of any slight redistribution of the tracer. A standard treadmill exercise is performed using the Bruce protocol, with the injection of cardiolite at the peak of exercise and the continuation of exercise for an additional minute. A 4-hour interval is preferred because of the additional reduction in background counts and to ensure optimum patient throughput. The first-pass radionuclide ventricular function study is a valuable diagnostic technique for the evaluation of left and right ventricular ejection fraction. Since cardiolite has favorable dosimetry and can be injected at a high-activity bolus up to 30 millicuries, it is useful for first-pass studies. As part of clinical trials, patients underwent 2 first-pass ventricular function studies. There was a high degree of correlation between cardiolite and the reference agent. The correlation was 94% for left ventricular ejection fraction. Simultaneous measurement of myocardial perfusion in the left ventricular function during a single period of exercise is possible with cardiolite. Investigators have demonstrated the feasibility of combined perfusion and function studies using treadmill exercise first-pass studies. This approach to evaluation of patients with coronary artery disease provided information equivalent to those formerly requiring 2 separate studies. The 3 types of information collected in a combined function perfusion study are presented here for a patient who underwent imaging with cardiolite before and after coronary artery bypass graft surgery. His ejection fraction increased and his ECG normalized after surgery. Tomographic perfusion defect size correlated directly with end systolic volume and inversely with ejection fraction at rest and during exercise. However, perfusion defect size often varied widely in patients with similar left ventricular function. This independence between measurements of perfusion and function suggests that simultaneous assessment of the 2 physiologic variables could improve the diagnostic and prognostic information of radionuclide tests. Cardiolite imaging has been utilized to detect, localize, and quantify myocardial infarction in several large studies. The diagnosis of myocardial infarction was made using clinical criteria which includes appropriate history, EKG, and/or enzyme changes. The presence of segmental myocardial perfusion defects was compared to the presence of a Q wave on the ECG or wall motion abnormality found on gated blood pool scans. Imaging was performed after injection of cardiolite at rest. After waiting 1 to 4 hours, planar static images were obtained for 6 to 10 minutes in 3 standard projections, anterior best septal LAO and steep LAO. The gated blood pool exam was performed within 48 hours of the rest perfusion study with cardiolite. The gated scans were obtained in the same 3 projections used for cardiolite imaging. Wall motion was also analyzed. A 16-frame cycle gated study was optional. These images were reviewed in a blind analysis. Shown here is a cardiolite study done in a male with a previous anterior septal infarction. The angiogram in this patient demonstrated a dominant right coronary artery and significant stenosis in the right and proximal LAD arteries. The patient was injected with cardiolite at rest, and images were obtained 2 hours later. The heart is enlarged. Both the right and left ventricles are seen. On the LAO view, there is a marked area of decreased uptake in the septum, which is faintly visualized. The anterior view demonstrates a large anterior and apical defect. The left lateral view shows a large anterior and apical defect. Overall, the images disclose an extensive infarction involving the apex, septum, and anterolateral walls. There was a 90% concordance in patients with the presence of ECG Q waves and abnormal cardiolite study. To summarize the results of this clinical trial, there was a good agreement between regional perfusion as demonstrated by cardiolite and the presence of abnormal wall motion studies and ECG Q waves in patients with previous MI. Thus, rest cardiolite imaging is a reliable means of detecting and localizing myocardial infarctions. A study was conducted to evaluate the efficacy of thrombolytic therapy in patients with acute MI utilizing serial cardiolite imaging. In the setting of acute MI, cardiolite can provide information on the myocardial area at risk and the extent of myocardial salvage after thrombolysis. With a first-pass cardiolite study, an MI can be evaluated post-thrombolytic therapy. In addition, recurrent ischemia and residual jeopardized myocardium can be assessed prior to discharge. In a pilot study, patients received 20 to 25 millicuries of cardiolite before or at the initiation of thrombolytic therapy. The first myocardial perfusion images were assumed to demonstrate the area of risk. Myocardial perfusion images were acquired as soon as the patient was clinically stable. The patients had a second study 18 to 48 hours later and a third study at the time of hospital discharge. The extent of perfusion defects on the second and/or third study was assumed to demonstrate the ultimate size of the infarction. A decrease in the size of perfusion defect on the second or third study comparison to that on the first study was assumed to represent the extent of myocardial salvage. This case shows serioplanar cardiolite images before and after successful thrombolysis of the left anterior descending artery in a patient with an acute anterior septal MI. The pre-thrombolysis images disclose an anterior septal perfusion defect. Quantitative analysis revealed a 33% change in defect size. Improved post-thrombolytic uptake of cardiolite can be seen in the septum and anterior wall. To summarize, the amount of myocardium at risk in an acute MI varies widely from patient to patient. As noted before, the size of the perfusion defect cannot be predicted from either the clinical presentation in the emergency room, the location of infarction, or the site of occlusion on coronary angiography. Cardiolite imaging permits determination of the amount of hyperperfused myocardium when the radionuclide is administered during acute coronary occlusion and prior to administration of a thrombolytic agent. A decrease in the cardiolite defect after thrombolytic therapy indicates successful reperfusion and myocardial salvage. SPECT cardiolite studies were obtained in a patient with no known coronary disease admitted for atypical chest pain at rest. Two-dimensional polar map displays were constructed from the tomographic slices. The study obtained during an episode of pain shows a large myocardial perfusion defect involving the anterior and septal walls. The ECG obtained at the time of injection showed T-wave inversion. The study obtained in the absence of chest pain demonstrated almost complete recovery of the perfusion defect. A 70% proximal left anterior descending artery lesion was subsequently found at angiography. The conclusions are as follows. A negative cardiolite study during chest pain rules out significant coronary stenosis with a high level of confidence. A positive study predicts with high accuracy the presence of significant coronary stenosis. A decrease in the size of a perfusion defect between the study obtained during chest pain and that obtained in the absence of pain supports the diagnosis of myocardial ischemia. The cardiolite SPECT represents a reliable, non-invasive diagnostic tool that provides not only the information obtained from thallium studies, but other additional important diagnostic information. This tape concludes the cardiolite portion of this training series. A review of cardiolite will now be conducted by the nuclear cardiology specialist.
America's first name in automotive innovation, Ford, is working together with the world's most trusted name in automobile safety, Volvo, on a common mission, developing breakthrough safety innovations to help protect children, keep families safer, and save lives.
We're renewing our commitment to driving American innovation. At the core of that effort is your safety, because every single life saved is worth it.
If you have an adjustable or interest-only mortgage, now may be the time to refinance and lock in today's low fixed rate from Ditech.com. We'll also guarantee you the lowest rate and fee. Log on or call 1-800-71-FIXED.
Hydrogen cars? I'm cool with that. Since a lot of the hydrogen that we'll be using will be created as a byproduct of clean coal power plants, we'll be less dependent on foreign oil. Want to learn more? Check this out.
At Beach's ultra-inclusive family resorts, everything you dream about magically comes true. Gliding and sliding and splashing with glee. Diving and dining, it's all included, you see. Even Elmo and friends from Sesame Street. Beach's makes every day in paradise perfect.
Book the vacation of your dreams. Call your travel agent or 1-800-BEACHES.
Hi, I'm Bobby Vandermeer, and this is my story. I'm a fairly new golfer. I've been playing for about 6 years with the Golden Girl Golf League. We all suffer from all kinds of arthritic pain. We're not real good golfers, so we have to take a lot of swings. It hurts your joints, and my fingers used to get it, my shoulder, my neck. And they said, take Aleve. It lasts all day, and it'll work. Aleve has helped to reduce all that. In fact, I don't have any pain when I'm golfing. I'm using it right now, and I don't hurt at all. No, it has not helped my score. Don't ask my weight, my age, or my golf score.
This is Carol. She's been called hippie, preppy, yuppie, protester, Democrat, Republican, mom, CFO, CEO, cancer patient, cancer survivor, fundraiser, spokesperson, caregiver, and soon-to-be world traveler. Reaching retirement is no small achievement. We'll help you make the most of it. Fidelity Retirement Income Advantage. Is your retirement on track? Find out in about 30 minutes. Call today, 1-800-FIDELITY. Smart move.
Has your small business come up with a big idea that's captured the market and is delivering blockbuster results? Then enter